Welcome to this morning's discussion of Seinfeld. The episode this morning will be the Sniffing Accountant. All right. So, any scene, any character catch your eye that you'd like to talk about? And there's no wrong answer. Please feel free.
I mean, for me, I guess the accountant, right? How someone's small behavior kind of spiraled this entire assumptions and episode.
So let's butterfly effect, right? And ever catch the movie, by the way? Well, it wasn't bad. I can't say I would. I'm not going to assign it, but wasn't a complete waste of time. I digress. So let's talk about where this goes and what this dynamic is. So your observation, who do you think catalyzes it? I mean, obviously the accountant's the focus, right? But in terms of the propagation, who do you think is the catalyst?
I don't remember his name, but not Jerry, like the other guy.
George?
Yeah.
Okay. Anything observed in George's behavior to support your observation? Like any particular scene, anything he said?
Well, in the diner, I just feel like he was more like not aggressive about it, but like enthusiastic about the idea and like, oh, you should like follow him and you should make this happen. And in the beginning, Jerry was just the one who's like, oh, did anyone catch that he was like, it was just an observation that led to like an assumption.
Right. So let's focus a little, focusing on the accountant's behavior. What happens in this group with the catalyst possibly being George? Okay. Anybody here watch previous Seinfeld episodes, or do we have any Seinfeld fans? Because one of the things we'll talk about quite consistently, and it'll relate directly to human behavior, is this idea that we identify a behavior and whether or not a psychiatrist has any purpose in discussing what's going on. Right now, usually in clinical practice, that takes care of itself because the way things are traditionally set up is that patients make an appointment to see us. So by the mere fact that an individual is presenting to us with what is referred to as a chief complaint or chief concern, there's usually a reason why. Okay, but when you're kind of discussing these different behaviors, maybe in a situational comedy, perhaps in a vacuum, we've got to be very careful, especially with people listening to us, that we're just not pathologizing behavior, right? So if anyone had seen prior episodes and therefore was familiar with this very character of George, my question would be, is this a pattern of behavior or is this just an isolated incident? Because usually patterns of behavior are what psychiatrists are really focused on, and things that just occur are really none of our business, right? I will assure you that this is a pattern of pervasive behavior or a pervasive pattern of behavior. Now, once we identify this, it may not be considered to be abnormal, much less disordered, right? So abnormal, just so we can get some terminology clear, is just behavior that falls outside of a culturally sanctioned norm. And then if abnormal, it's still none of our business, unless it's disordered. What is your appreciation, whether it relates to George or not, the sniffing accountant or not, what is your appreciation of the definition of disordered?
If it impairs someone's day-to-day functioning, so social functioning, work, getting in the way of them living their life as a quote-unquote normal.
Okay. That is always the line to cross. And that is something the clinician should always have on the forefront of their mind when they're interviewing a patient, client, consumer, or other. Right. So it's always going to be that line. Does that apply here?
Not necessarily, I guess. Like you said, he does it all the time, and it caused them like more distress to like go out of their way and like follow him and figure out what was going on. But like, I guess that was supposed to be like the comedy part of the sitcom, so like it didn't get them in any significant trouble.
If you were to ask anyone who was in that group who followed this, for lack of a better word, instigator, might they tell us different? Might they say that this was a source of frustration? And who would that person be? Because remember, when we think of being clinically significant and when we think of there being impairment, not only is itself, but it's others as well. And that's why it's so important to talk to collateral individuals who might give us a different story or a different impact than the patient, in this case, himself. So if that is the case, and let's assume that it is because we want to make this an academic discussion, what might be going on here in this particular character will still remain focused on George. If now we're at a point where we're saying this is a pervasive pattern of behavior that appears to be clinically significant, therefore there's a disorder that we should perhaps discuss, contemplate, or otherwise formulate. Without getting into actual pathological diagnosis and just slapping labels, what do we think may be the etiology of this? What do we think is actually going on?
Well, I was kind of thinking maybe being a little extra paranoid, but I don't know if it's justified because their money is on the line because they were depending on the accountant for their money. But I was more thinking about like a personality disorder, especially the paranoid type, or versus delusional if it's a pattern kind of thing, if it's been going on greater than a month or so. But just looking at one episode, I think they were, I don't know if it's right to call them paranoid personality versus normal, because if I were in that situation with that a big amount of money being on the line, I don't know if I would do the same, but I would definitely look into what the accountant was doing to be, I wouldn't want to lose all that money. So.
Yeah. And, again, it gets the general idea that if, and you're putting yourself in that situation, I would, though, reply that your behavior then would be in isolation. I could explain your behavior as being, let's say, state dependent. That is, it's prompted by the very situation that you're in, right? So, but we've already established that that is not the case. While it should be our first consideration for George or anybody else in this particular episode in this situational comedy, it's not the case. That is not shared with you. There's something else going on. And I think what you identified is a potential. And that is, if we're going to say that George Costanza is demonstrating a pervasive pattern of behavior consistent with having a basic mistrust and suspiciousness of others, that is the hallmark trait of the paranoid personality. Now, we're not going to go so far as to say that George then is diagnosed with paranoid personality disorder, but that's how you formulate your diagnosis. There's this pervasive distrust and pervasive suspiciousness. Teaching point. You are going to be required to know the personality disorders. You're going to be required to know them for the next 6 weeks of your life as you practically apply them in clinical practice. And you're going to definitely have to know them for that infamous Friday, that sit down with the shelf exam. When you are studying for the personality disorders, I know that the American Psychiatric Association has a classification system where they break them down into 3 groups or clusters. These groups cluster features that overlap, and that's fine. However, I think for study purposes, for learning purposes, it's probably a better idea to reorganize them. Reorganize them into 2 columns or groups, one in which adheres to a cardinal trait and another group that does not. The one that adheres to a cardinal trait, I think, is learned much more simplistically when you know the cardinal trait. And when you review then the DSM criteria in your favorite board review text, those criteria simply morph into examples of that cardinal trait. I mean, you'll go through them 1, 2, 3 through 10, and you realize, oh yeah, example 1, example 2, example 3, etc. And they're easily retained that way. For those in the other column that you just don't have that platform, you don't start out with that cardinal trait, it may be a little bit more time consuming to remember those diagnostic criteria, right? Because they'll remain as diagnostic criteria and not examples of something larger, right? That said, the paranoid personality disorder is in that first column. It does have a cardinal trait, and that cardinal trait is that pervasive suspiciousness and distrust of others. Now, tonight, when you review, again, whatever board review text you're using, you'll review those diagnostic criteria, and there'll be examples, one after the other, of that pervasive trait. Just for completeness sake, before we move on to your next character, what are the other 2 personality disorders that are part of cluster A, that is that APA classification system? That's two? Perfect. Okay, all right, so for completeness sake, they are your cluster A personalities, by the way. And this is just where to prompt your study this evening, Friday, Monday, is both of them also adhere to a cardinal trait. Good news. So we're going to stick them in our new classification or newly classified first group. All right, other characters other than George you want to discuss today?
I have a question about George. So if you watch more of Seinfeld, do they ever address that, or is it just something that you get?
Oh, yeah. Oh, yeah.
Oh.
Yeah, and
We saw an isolated episode of that.
Yeah. Yeah, and you know, for George in particular, I've said this more than once, and I think this is me talking to me. George Costanza, unlike Jerry, and I think unlike Kramer, does not have an obvious or evident diagnosis. George's diagnosis can change with each episode. You can literally create an entire curriculum of psychopathology based on a selected episode of Seinfeld focusing on this character. All right, so and because of that, he's I think the most real character there is in this situational comedy, because similar to George, who just absolutely defies the DSM or the APA classification system, he doesn't fit neatly into one. He fits them all, depending on which episode you watch. That's the way people work, right? Again, we always talk about our patients not reading the textbook before they present. George has another layer, I think, of training and education beyond the actual characteristics he might be portraying or demonstrating for any particular episode. And that is this reminder that our patients simply are not going to neatly fit into these artificial categories. Right? They just don't. And George doesn't. But yes.
We could also talk about Elaine.
Mhm.
I remember when her boyfriend was taking down phone messages for her. She was really fixated on a point how she didn't use a proper punctuation of exclamation mark that Myra had a baby. Something that reminded me of that scene was obsessive compulsive disorder versus obsessive compulsive personality disorder. The fact that she didn't the messages weren't the way that she exactly wanted. And I also saw how it affected in her job that I think it was her manager who told Elaine to get rid of the punctuation marks, even though she really loved having them in her text. So the fact that it was kind of getting into her life work, maybe it's gearing toward OCD versus personality disorder.
Yep. So what you identified and the behavior that you're discussing, I think is a depiction of an individual, Elaine, being overly focused on a detail and losing the bigger picture. And therefore, if it results in failure of task completion, is certainly suggestive of obsessive compulsive personality. Okay. So be very careful. This is something I ask literally every 6 weeks. And I can tell you right now, it's a trick question, right? It's a tricky question. What is the difference between obsessive compulsive personality, that personality disorder that does incorporate that very observation you made, that attention to detail, where the larger task is missed and therefore there's risk of failure of task completion, versus obsessive compulsive disorder? Now, your answer cannot contain the words syntonic or dystonic. I'm trying to rip you from those board review texts.
Maybe like for the personality one, you want to be that way, while disorder one, you don't like the fact that you're that way.
So remember, this condition called obsessive compulsive personality disorder is a disorder, meaning that it results in clinically significant distress or impairment. So personality disorders, like any other mental disorder, adhere to that cardinal rule. So in that way, OCD and OCPD are actually the same or similar. So we have a patient here, picking our sub-Is, that is OCD and another that is OCPD. How is patient one with obsessive compulsive disorder likely to present to clinical practice?
wants to change, upset by his behavior versus she may think it's helping her and I'm trying to use symptomatic and withdrawal.
Yeah.
But like, it's more of a strength, like,
So you're basically using the terms without using the terms.
yeah, of course.
When you say he's less likely or would be more concerned about his behavior, what behavior? Compulsions and/or? Yeah, it's that easy. If someone presents with OCD, that anxiety disorder, if you have any hesitation of what that presentation may look like, look at the title of the illness itself, because the diagnostic criteria are actually contained in the illness's label. The individual presents with clinically significant obsessions and/or compulsions. Right. On the other hand, how might our patient number 2 present? That's exactly right. Without obsessions or compulsions, because if she had clinically significant presentation of either, we would actually diagnose her with having OCD. In the absence of those, there are signs and symptoms, diagnostic criteria that meet what we would all refer to as the type A personality, including but not limited to that attention to detail, as previously discussed. They are 2 absolutely different presentations, and you have to remember that. Now, is one egosyntonic and dystonic? Sure, why not? But you can see that you're kind of missing the bigger picture. That's like comparing an ant in the Empire State Building and saying, well, one is usually black and the other one isn't. That's true, but I think you're missing a bigger picture, right? So, with all due respect to those that publish those books, the fact is that individuals who present with A versus B are going to present quite differently, and you don't have to worry about knowing what syntonic or dystonic even is, unless of course you're taking the board exam. All right. So Elaine has this attention to detail. For completeness sake, and by the way, obsessive compulsive personality disorder, yes, is in that column A in our revised system, where it does adhere to that cardinal trait. That cardinal trait is perfectionism and control. That is your type A personality. What are the other 2 cluster C personalities? Now referencing that other classification system of the APA. Borderline is in cluster B. Avoidant and that's it. There's your 3. Okay. All right. Anything else with Elaine?
I remember her doing something.
Fair. Not everybody who binges ice cream has a problem. 99% of the population who binges ice cream is completely normal. All right, so let's say, however, Elaine presents with signs or symptoms that are clinically distressing, and you want to evaluate for anorexia versus bulimia nervosa. What might her presentation be in addition to observed binge eating to have you think that maybe anorexia nervosa should be a clinical consideration? BMI. Why?
Just because if her BMI was like less than 18.5, that would automatically classify her as anorexia, even if she has the bulimic tendency.
You're 99% correct. You're almost fully there. Anybody? There's a little bit left. So physical sequelae to support the provisional diagnosis is almost, again, tricky for a lot of clinicians, but very, very important. The BMI is in fact DSM, a very important DSM criterion, and one that does readily differentiate from the other, or one of the other eating disorders called bulimia nervosa. The reason for the low BMI is certainly something that we have to understand as clinicians. There is a fear of gaining weight. The full sentence is that there's a fear of gaining weight despite being underweight. And then the BMI comes in to readily identify and operationalize what underweight means, right? So BMI, absolutely true. But I think the larger picture is there's a fear of gaining weight despite being underweight. That is not the case in bulimia. That is not a part of the definition of bulimia.
I know that the criteria like the BMI listed, but I guess when I've learned about users, I know there's like also approach to make sure that NLP is diagnosed even above the BMI. Does that happen in clinical practice that you're looking at these other signs that the BMI to diagnose and be with NLP? Like if you're being, all the other things stuff that's under the BMI.
Yeah, I mean, if you were met with a clinical situation in which someone who presents to you is underweight, but has a BMI of greater than 18, but because of their fear of gaining weight, is demonstrating behavior that you believe is clinically significant, including physical sequelae, I don't think a clinician would say, we'll retake your BMI, but unless you're 17.5, there's nothing we can do for you. I'm not sure if clinicians would ever do that. Right, so yes. Bulimia, on the other hand. So I said, did I say bulimia and anorexia? Bulimia, on the other hand, may also demonstrate or present with binge eating and purging behavior. So the binge eating and purging does not differentiate anorexia from bulimia, right? Because anorexia does have a binge eating purging subtype. So if a person presents with episodes where they eat more than usual and then have compensatory behaviors, for example, purging, vomiting, that does not help you on a test. That's choice A, anorexia, choice B, bulimia are still in play. That fear of gaining weight despite being underweight. On the other hand, in the absence of that fear, and therefore in the absence of being underweight, that compensatory behavior, that binge eating and purging, is likely bulimia nervosa. That's an eating disorder that is actually defined by the behavior itself, not the fear that is the etiology of the behavior. And that's what really separates these two illnesses. Anything else for Elaine? Any other characters you want to discuss? Yeah, I think that's the low-hanging fruit. We should definitely talk about substance use disorder. And what substance would come to mind? Yeah, stimulants. Right. Stimulant or cocaine intoxication. How might that present on a shelf exam or clinical practice for that matter? Grandiose. Euphoric, euphoria, insomnia. For all intents and purposes, individuals who present with a panic attack on a shelf exam are diagnosed with stimulant intoxication until proven otherwise. Period. It looks and is clinically indistinguishable from a panic attack. Right. When that presents with everything you just named, right? The pupillary constriction, the pupillary dilation, the diaphoresis, the tremor, the tachycardia, arrhythmia, etc. How do you differentiate that from an acute MI? Yeah, right. A panic attack is nothing more than an acute MI without evidence of myocardial injury, right? So the EKG and the serologic markers, period, right? And by the way, cocaine can induce both. So whether a person on a shelf exam, a psych shelf, presents with an acute MI or a panic attack, it is cocaine induced and proven otherwise. All right, so that's cocaine across the board or stimulant until proven otherwise. The hints on the shelf that have been somewhat consistent and reliable are nasal septal erosion or even perforation or epistaxis. So that will hint of the intranasal route, that will hint of cocaine, and therefore stimulant-induced panic or stimulant-induced myocardial infarction is a single best answer. Stimulant withdrawal. So it's the opposite of panic. So what is it that you're describing? Even simpler than that. It's a major depressive episode. Somebody presents with a major depressive episode is clinically indistinguishable from stimulant withdrawal. Now, one thing that comes up on shelves, and it maybe is not as reliable as previously discussed, is that the insomnia includes vivid dreams. Now, could vivid dreams occur in somebody who's depressed? Absolutely, but it's actually a part of the diagnostic criteria, insomnia or vivid dreams of stimulant withdrawal. There is no physiologic withdrawal phase, so there is no detox. There's no medical management of stimulant withdrawal, meaning that treatment of withdrawal is supportive. Individuals are dysphoric, they're at risk for suicide. So,
dreams is for any stimulant withdrawal?
yes. Mhm.
Was there a reason behind that? Is it because the stimulant was a process of more behavior and the fact that going on to all like reactivates that, or?
My gut says at the neurobiological level, it has something to do with serotonin. But I don't, to my knowledge, it hasn't been fully teased out. I honestly don't know. After your patient is through the withdrawal phase for stimulant use, let's say the accountant's sniffling, was in fact the result of stimulant use disorder. He goes through a withdrawal that does not include a physiologic withdrawal phase. That is, there's no medical detox. Treatment is supportive. He's provided that he's through his withdrawal phase. When you examine him, there are no signs or symptoms that are consistent with a depressive cluster. Treatment. Yeah, it's going to be psychosocial rehabilitation, and the easiest example of that in this case would either be AA or NA. And then I know we're up against the bottom of the hour. What is, and we'll be talking about this and revisiting this more than once in the next 6 weeks. What is the only criteria for an individual to attend AA or NA, other than your clerkship director telling you have to go to successfully pass your clerkship? Yeah, it's a desire not to use, period. It's something very important to remember. Right? So a person that walks in may walk in for their own reason, and they can participate in the meeting. And that's an important thing to discuss with people who you believe would benefit from attending these psychosocial rehabilitation groups when they tell you that I'm not an alcoholic or I'm not an addict. It doesn't, you don't have to be. Right? If you want to get people to stop heavy use because you want their antidepressant to be given the best chance to work, you should be discussing AA or NA with your patients. All right, at the bottom of the hour, we're going to leave it here and then log back on to have work rounds or table rounds. Thank you.